Ladies and gentlemen, welcome back to the session. Please come and get seated.
The symposium, please come quickly.
We are about to start the session again. Please come and join with us. We are about to commence the scientific sessions with the first symposium, which is on Trends in Child Health and Nutrition Wellbeing, dedicated to Professor Priyani Soisa. We would like to observe a 1-minute silence on behalf of later Professor Priyani Soisa. Thank you all. Let me invite Professor Narada Varnasurya, past President of Nutrition Society of Sri Lanka, former Vice Chancellor at University of Jayawardhanapura, General Sir John Kothilawala Defence University of Sri Senior Professor of Pediatrics, General Sir John Kothilawala Defence University of Sri Lanka, to chair the session.
Right. Good morning. I must say I am very pleased to chair this session, which is in honor of my teacher, my guru, and my mentor, Professor Priyani Soisa. And I'm also very pleased to chair this session because the three speakers in this session are all my colleagues. So without further ado, let me introduce the first speaker, I think who is very well known in nutrition circles, Professor Pujitha Wickramasinghe. He is a senior professor in pediatrics at the University of Colombo, and he is a honorary consultant pediatrician at the Lady Ridgeway Hospital for Children. His special interests are in child nutrition, childhood obesity, and metabolic syndrome. Pujitha will now talk on trends in child health and nutritional well-being. Yes. And growth in early childhood.
Thank you, sir, for the kind introduction. Ladies and gentlemen, I consider this as a singular honor bestowed on me to deliver this plenary lecture on a symposium dedicated to late Professor Priyani Soisa. Although I had not studied under her, but she had inspired me in many ways in my career. So, nutrition, feeding, nutrition and growth, I think is an integral important part of child nutrition in this country as well as all over the world. And if we just look at the world statistics, we know about a third of the children are either undernourished or overnourished, that is improperly nourished, and about half of them also have a hidden hunger or micronutrient deficiency. The triple burden of malnutrition is there, which is affecting individuals as well as economies of nation, and there are a lot of factors which will be contributing to all this in a negative manner. So it is important that food systems as well as food environments are created, and if we do not actually invest on nutrition properly, the SGD, achievement of SGD is just only a mere paper exercise would be, but not we will be realizing that. So it is important that we develop food systems and have a good understanding, because food is not something that can be dealt by a single group of people, because food is a multi-sectoral involvement, and I think Nutrition Society is a good example where the whole, everybody involved in nutrition come together, because sometimes this is taken as the ownership of the ministry. Has its own problems like poor growth and ultimately affecting the earning potential as an adult. On the other hand, if there is micronutrient deficiencies, more or less frequent infections, poor educational achievements, as well as ultimately having a poor health and risk in death. And over the last quarter century or so, all over the world, the rapidly spreading epidemic is the overweight, which is of course is now only catching the attention of the public as well as the policymakers and other relevant parties, which of course has a huge impact on the non-communicable disease burden in the long run. So you all may have heard about the 1,000-day concept, starting from the conception going on to the second birthday. And it's a very, very important period in life of any individual, because it actually sets the foundation for adult health, wellness, economic capacity, and then general well-being. So these 3 years are very, very important. And of course, in the first 2 years of life, which I mean here is after being, but life actually begins at conception. And then, but in this context, I had discussed the first 2 years where they are in the open environment living with us, where it is also important on the brain development, acquisition of language skills, sensory pathway developments, and development of higher cognitive functions. Then on the other hand, so that is if we don't provide the adequate proper nutrition in the first 1,000 days. Also, in the improper manner, again, if we are providing the nutrition and looking after them, they will not be able to attain the highest, fullest potential in growth, which again can have a lot of consequences. And on the other hand also, it sets the stage for the development of non-communicable diseases in the long run. And there are two hypotheses which I believe both together actually, that is fetal origin of adult diseases, which came through Professor David Barker from Southampton, which what he highlights was that if somebody was disadvantaged during the fetal period, they will carry it on to their adult life. But of course it was to a certain degree not exactly challenged, but the contributory factors were shown by two authors, Atul Segal and Alan Lucas from University College of London, where they proposed the postnatal growth accelerating hypothesis, which says that if they were born small and if they grow at a faster rate by the end of first year or second year, then of course they have adverse consequences. We also have done some few work in the local context, which we also have shown that accelerated growth within the 6 to 18 months of life of the low weight people, children, or even in the normal weight children, which would have ultimately end up with having high fat mass at 11 to 13 years of age, rather than having a advanced linear growth, which again shows that of course the fat mass is the direct culprit or the direct factor that is related to the non-communicable diseases. Further, there had been another cohort of study which we have done retrospectively actually, where we looked at the birth weight and different metabolic profiles at 5 to 15 years of age, and you could see that the ones who were born small, the blue block on the right, who is in the front, and if they remain small at later age, they are metabolically much more protected than those who are in the same birth weight tertile if they gain weight later and go on to a higher BMI. So this is something which we should bear in mind. So just being born small alone is not going to cause a big problem, because the damage already has happened. So at least some damage correction could be done by trying to make them grow in their inherent line rather than trying to overfeed and try to get them into a larger or higher growth trajectory. So we are all born actually with a certain genetic predisposition to or susceptibility to develop diseases or non-communicable diseases in the long run. But different stages of our life we get exposed to different contributory factors which push this back line or a line away from the black and fill in the blue area, which is the accumulation of the risk. And further we have aggravated environmental condition, because the genetics we can't correct, but the environment we could correct. But if we do not correct or do not manage it properly, then the yellow line gets further and further apart. So that does mean what happens is at an early stage they would begin to show morbidity and mortality related to non-communicable diseases. So if we can keep this yellow line as low as possible, that would be the best thing. But trying to do that also has a time period where we have the plasticity or the moldability, malleability in the early stages of life. A child, we could correct or rectify any abnormal metabolisms earlier in life, and it will be much more difficult in later in life. So you can see the green triangle gets smaller and smaller when it moves along the age towards the right. So earlier the interventions, it's much better to keep the top line as close as possible to the bottom line, which is the inherent problem. So the distance one has to move to come to a near normal level or acceptable level in childhood is much more lesser compared to the adult age group. So that is where the factors of maternal diet, maternal body composition, and then offspring diet and offspring growth matters, because we see not only the offspring diet, but of course the obese mother is also a big problem as far as concerned the health of the offspring. So the other thing is, during childhood, if we feed them excessively, they can become obese. And how do they become obese is by putting on more and more fat cells in the body. It is not the enlargement of. So you can see the two lines, the obese line as well as the lean line. They keep on increasing the number of adiposity shown in the y-axis. But after, when they end their teens and enter into the third decade of life in their 20s, you can see it plateaus. So if they start life with a small number of fat cells, it's much better than going and having a large number of fat cells from childhood, because it is not possible to bring them down easily. And this study further shows that in the first graph you can see the bar charts, you can see that the number of fat cells, now this is actually after surgery, bariatric surgery. You can see the volume, first two bar columns shows before and after the fat cell volume, which of course comes down. But the fat cell number does not come down after bariatric surgery. So that means there is already available tanks to be waiting to be filled by, if you take a high energy diet, which will get converted and it will get filled, and you will not sustain the linearity after bariatric surgery. So bariatric surgery will not be very, very useful in that context of lowering. So this is why 75% or more of obese children end up as obese adults, and then less than 10% of normal children only become obese. So that's why what will happen is obese adults will go on fasting for many days, but feasting of few days will end up all that had been fasting and trying to get into diet. So that's the important thing, is that you should let the child have the least amount of required fat cells only, or the fat composition, rather than trying to make them obese, expecting them to be lean later, which is of course a very, very hard task. So coming on to the feeding of children, of course we know that the feeding is of course parallel to certain motor milestones or other cognitive milestones that the child has to achieve during the course, because feeding is a somewhat a complex process. From going on from a total liquid diet, they gradually transition through semi-solid, going on to adult diet by about 12 months of age. So for that, of course, they have to achieve certain milestones, certain abilities have to be developed, and you can see at 5 months when they begin to convey objects, place in hand to mouth, and drinking from a handheld cup are some of the things. Handheld cup means fed by someone else, and then reaching out for objects and conveying them to the mouth are some of the milestones, which of course you can again see by 9 months they will be able to have finger foods. Then 18 months you can see they will become little bit of adamant or boisterous or whatever way you call, where they are determined to independence in mealtime. These are some of the important milestones which we have to negotiate and identify, otherwise always there will be conflict between the parent or the caregiver and then the child. And by 2 years also they express their own self and independence, and of course they have often irrational food refusal, which also is causing a lot of distress among the caregivers. So some of the more important aspects is that you can see around 6 months people or children begin to eat pureed, mashed and semi-solid food items. Then 8 to 9 months again pureed finger foods, and by 12 months family food. If we miss these proper windows, if we don't encounter on these things, then of course there will be arduous task of getting them to eat properly. Now a crucial window is of taking lumpy food is 4 to 10 months of age. Many people, what we see in the community is, because they want to get the child to eat large volumes, they give total pureed where the child has only to swallow, but ignoring their normal development milestones. And ultimately what will end up is around 1.5 to 2 years, all of a sudden parents will come into light that the child is not munching and taking solid or refusing total solid, because we have missed the crucial window in their development, especially with the teething and all. They will get used to those habits, which we are totally ignoring because the focus is mainly on feeding the child and trying to achieve a higher weight. So after trying to introduce semi-solid foods after 10 months is going to cause a lot of problems in the long run. So the malnutrition during this critical period will definitely impair the growth, significantly affects the morbidity, and delay motor, cognitive, and social emotional skills, increase risk of non-communicable diseases because there will be large volumes of eating, but they will not be 100% required healthier, fulfilling the nutrient requirements of the child to a great extent. Now, last year, the WHO came out with a new guideline on feeding for the complementary foods for infant and young children from 6 months to 23 months. They discuss about 7 points, which I will try to take you through quickly. So one is the continuation of breastfeeding. Of course, we have very, very high rates in this country, but we can do very well, better than this by actually one area that we have to strengthen in this country is actually to provide more and more support for the lactating mother by actually supporting at the workplace, because we have a sizable workforce of females in this country. Then access to breastfeeding counseling, because sometimes they may not get the proper advice, guidance they require. And then of course the protecting from the market exploitation, which is of course is a very, very powerful force, which of course adversely affect the children in the long run. So I don't have to explain to you all the benefits of breastfeeding, of course from the baby going on to the mother, as well as the economy. Economy of course is twofold, not only to the child in the long run, but of course to the immediate situation, even to the parents, of saving a lot of due to the prevention of morbidity and requirement of the utensils, all sorts of those things. So breast milk substitute, of course we have to bear in mind, as any case, that a very, very small minority may require or may not be able to be fully successfully breastfeed fully. So they may have to have the support of certain modified formulae or some other alternative milk product. So dairy products are the commonly used source that humans consume. And what the recommendation is actually from 11 months or 6 months onwards, they say that actually even animal milk could be given apart from the milk formula. But of course the guideline vehemently says that after 12 months there is no need of introducing any formula. Fresh milk could be given. But of course personally I don't agree with that, because still in this part of the world we do see little bit of allergies, and cow milk could cause allergies, and especially GI bleeds could be seen. So whole milk delaying beyond after 1 month first birthday would be much more prudent, but of course after 6 months they could be given full fat milk. So this slide of course is a UNICEF by region that has shown how the rise in breast milk substitute, but of course we can be proud as South Asians, it's 6% or less in this region use of breast milk substitute, and I'm sure in Sri Lanka in the first 6 months of course it is much more lower than this. So there are various factors that influence this additional milk intake, and milk protein is an important source, whether it's a human milk or any other form of milk. But of course it has the problems also. That's why I said under 12 months it could have a high solute load, which is causing problems to the kidneys as well as the risk of GI bleeds. And then of course what the data have shown is that there is no advantage of using formula milk over and above using whole milk or animal milk directly. So that is what we should bear in mind. So although there may be coming up with different fortifications, the formula, there has been no scientific evidence to show that it has any advantage over and above the use of unmodified milk. So then complementary feeding, of course, there is a time period which we go on till exclusive breastfeeding 6 months and after 6 months. But of course, there is also important to understand that a child will be ready more or less to take complementary food after 4 months. That does not mean we have to introduce. Why I am saying that is sometimes the mother may not be available. Sometimes there is a minority again who will not be able to survive or provide the adequate nutrient intake through mother's milk. So in those cases, when they begin to show growth faltering around 4 months of age, it is important that you introduce them. Because what I have seen in practice is sometimes people think till 6 months the child cannot be given solids. There is nothing like that. If the extrusion reflex is not there, because we know small children are born with a safety reflex where they put out whatever solid material come into their mouth. That is to prevent them getting choked. But after about 3.5, 4 months, they go off that, their coordination becomes, oropharyngeal coordination becomes better, and then they can selectively swallow pureed food items. So the message, important thing is that there is nothing saying that till 6 months children cannot be introduced food. No, they can be introduced food from 4 months onwards. But if the child is growing very well, mother is available, then definitely you can continue with exclusive breastfeeding till 6 months. But if mother is not available, or the growth is faltering where the mother's milk is not sufficient, then of course rather than going on to other source of milk, straight away starting on complementary feeding is the more important thing. Then so complementary feeding is a process of providing foods in addition to the milk when the breast or other formula milk alone are no longer adequate to meet the nutrition requirement. Generally, this is at 6 months. So that's why I said even at 4 months we have been seeing this, and introduction of complementary feeding early in life would be advantageous rather than introducing any other food item. So good complementary food should be definitely energy rich, not containing other extraneous spicy or salty, easy for the child to eat with a good consistency, linked by the child's palatability, liked by the child or palatable. And the other thing is it should be, of course, of indigenous seasonality, because research have shown that the GI or the gut microbiome plays a huge role in our health. And the gut microbiome is actually locality specific. Even in larger countries, they have shown that the diversity of the diet over ages of evolution has shown a huge impact. Now, there are studies to show where undernutrition treated by other food preparations which are not indigenous does not bring a full recovery of the individual until you introduce some indigenous food items which will help the growth of the flora. So it is very important that we sort of emphasize people to stick to their indigenous drugs, indigenous food items, rather than just trying to go into fashions and try to depend on certain imported food items, which we can see also in the country happening at the moment. So these are just volumes. The most important thing is we should know the volume that the child can bear, because when parents come and say child is not eating enough, how do we know not eating enough? The parents are not the judges, the child is the judge actually. But there should be a reasonable volume, reasonable amount of time should be given for the child to empty his or her own stomach and then take. So a rule of thumb is roughly about 50 milliliters per kilo of body weight, so which works out to about 100-150 milliliters for about 10 kilo child, so something like that. So it, on cup sizes you can see at different ages it changes, and this is what is parents have to, as well as the carers have to understand. It varies from child to child, it varies from meal to meal, because there are certain food items which will hinder gastric emptying, there will be certain food items that will promote gastric emptying. So depending on the previous meal, they will adjust for their requirement. But parents, of course, caregivers always thinks the child was eating this much, why not he is not eating this much now? Because in the morning meal he was able to eat a 3/4 of cup, now he is eating only half a cup. There is variation, so that has to be taught and understood very well. So one of the biggest problems is people are not patient when they are feeding children, and then of a variety of bite sizes of food. So these are some of the things that could be done, and actually we know we don't have proper responsive feeding in this country. They are just distracting and trying to put something below the throat and try to fulfill the or empty the plate. So one of the main thing is the parents want to see a clear plate. So it is jargoned as clear plate syndrome, where they just feel something, they think this child can eat, and at the end of the day child has to eat. Whether it takes half an hour, 2 hours, 3 hours, they somehow or another wants to fill. And then what will happen is the next mile also get compromised. Then of course we know that the growth rates decrease. The child's abilities, as I showed you in the few minutes ago, the other previous slides, the abilities develop. They begin, once they become 1 year, 1.5 years, they are explorative. They want to go and say they are inquisitive. They will eat just only to overcome their hunger feeling. Not that they have to, they never take a nutritious sort of a meal. They don't eat for nutrition, they eat for hunger. So that has to be understood very well. So that where the picky eater comes into the picture, and we have to make sure that the diet is structured in such a way that it will not be overlooked. And imitation is one of the key things which we never encourage. That's why I always tell my patients, whenever they start complementary feeding, it should be where the other members of the family begins also eating, because it should not be somewhere else. Some people are doing it in the living room, somewhere else, or in the outside, and it's basically distraction feeding, because we know children begin to imitate the others, and then they come and say, yes, when we are eating, he tries to pull from our plate and take it. That is the normal thing, because he thinks he is not being given the food, whereas he will be given something totally unpalatable, cannot be eaten, and ultimately they end up with poor feeding practices or poor learners in that aspect. So diet diversity is also another important thing, because by providing that diet diversity you will be able to give a fair amount of. So WHO has identified 8 main areas, including breast milk, then animal food, dairy products, the eggs, legumes, vitamin A rich, and other vegetables and fruits and other ones. So a minimum diet diversity score of about 5 out of 8 is expected. But of course, unfortunately, again, the South Asia region is showing a poor diet diversity of something like 25% or so. But of course, in Sri Lanka, we had done a small study which has shown a little bit better than that. So I'll skip this slide. Then coming into unhealthy food and beverages, starting from a younger age, this is also another exposure, because we know that one of the biggest thing is that parents want to go for commercial products in a very, very young age. Even at 9 months, 10 months, they try to give. So some of these products do have ingredients which of course make them more palatable, and then they get sets into a certain pattern. And especially what we see is, if a child does not eat, then they will be given the easiest snack of a biscuit. So biscuit is of course is a sugary material, easy to eat and much more tastier than other nutritious sort of a prepared meal. And then children take a wrong twist and a turn at this point. So it is very, very important that to avoid this. So unhealthy foods and beverages from a very young age itself should be curtailed and should not be introduced, because it sets a wrong trend in their feeding habits. So then nutrition supplementation, of course, it's to a certain extent we need that, and we have certain programs that are operating, and the WHO also have provided that, because especially the multiple micronutrients, because especially after breastfeeding, we know that the micronutrient status will not be maintained, especially coming from the divalent cations like zinc and iron, and those are of course needed for the metabolic processes, and if the metabolic processes get affected, naturally the hunger will be not set in. So as a and the appetite will not be there. So because of that, the 2-month courses or 60-day courses of multiple micronutrients, which is of course happening here, is practical and it is providing a service. Then of course the vitamin A mega dose, which are the local programs which are there. So some fortified commercial products at certain points of time, depending on the requirement, may have to be used. If it is using of course commercial products, then going for fortified products is the best option, and that will also help in certain prevention of certain micronutrient deficiencies. But of course, having said that, the balanced diet of natural food is always the superior compared to any of the other commercially available products. Then responsive feeding, as I said earlier, 3 pillars are there where the child signals of hunger and satiety will be sent. Then the caregiver should be able to recognize those cues and respond to them. And then the child will set on this experience and begin to expect that in response. So that's why I say the imitation is very, very important in this responsive feeding, where they will learn a certain pattern and they will take on to that pattern, which in this country, unfortunately, people want to give a quantum. They come with a prepared volume and somehow or another want to provide that rather than responding to the needs of the child. So as I said earlier, we did a small study, one of my PhD students, on infant and young child feeding practices from birth to 2 years, which we published. And we saw at a cross-sectional and longitudinal level how does the breastfeeding changes. You can see that at cross-sectionally the breastfeeding is 100%, but with the period of time in time intervals there is a slight low. That's, as I said, always there is a very tiny minority who will not be able to breastfeed due to various reasons, maybe maternal reasons, maybe infants reasons and various things. But of course overall you could see that there is a large and the solid introduction is much more later in life, and mixed feeding is predominantly. Then if you see that now these are different time gaps in months in the x-axis, and the blue column shows the minimum diet diversity, which shows about more than 50% in the initial phases, and then gradually with time reaches almost about 90%. So that is fairly satisfactory, because this is actually dietary advice given by a trained person, single person to this cohort. So it is, that's why it is very doable. The problem, as I highlighted earlier also, it's important that there is proper counseling facilities are made available for them to get the help and get guided. So then minimum meal frequency, again, once they come into 9 months onwards or so, is satisfied. And then minimal acceptable diet, as well as egg or other animal product fulfilled to a great extent. Then of course looking at the complementary feeding indicators at different ages according to the local live ICF guidelines of the Family Health Bureau, where the age appropriate consistency, that's the blue bar, then the orange bar, age appropriate quantities. In the initial phase it is there, but later on slight ups and downs are there, and you can see when it comes to the last 2 groups there is a little bit of effect of the age appropriate consistency, because how much you say, sometimes they go on to the wrong way of feeding the child with the wrong consistency, but of course getting rectified later on. So although WHO has its guidelines, I don't think we should, because we have to make sure, understand WHO prepares these guidelines for 200 odd countries. and we should not be taking that as the gospel truth and using, because they are more or less, we have to understand them as generic guidelines. So we have to adapt them and then only afterwards adopt them, because we should not be taking them en masse, because it has to be tailored, whatever the guidelines comes, to see the suitability of the local context in whatever country. So a quick word about growth. Growth is actually, poor growth is not equal always malnutrition. Malnutrition leads to poor growth, but growth is not solely due to malnutrition per se, especially when you take linear growth. It is multifactorial. Genetics of course play a part, but more than that also the environment which they give. So I took two components here on the right hand side, where there are what is called adverse childhood experiences. There are 10 such experiences. Directly they are not actually related to nutrition per se, but of course they shows an adverse effect on the child. So because it causes stress and all sorts of difficult situations. Then of course there is another new concept coming out on nutrition or on growth, which is called the SAPE concept: social, economical, political and emotional. So although the last few years which we had a lot of stresses from the societal point of view, COVID, economic downturn, all sorts of things, and attributing that the child malnutrition is purely due to nutritional deficiency, I totally don't agree, because even the child stresses, although for not maybe that much for younger ones, but of course still the parents are stressed, that do get transmitted to children, and then older children will have uncertain futures, their schooling has got affected, all these things mount to their stress. So there is a lot of work coming up and showing that beyond nutrition there are many factors which are influencing, which could be the reason, because for the last 25 years in this country, if you take the malnutrition rates, it has plateaued. So why nobody could explain, having programs one after the other, but we have undernutrition or stunting, wasting, all those things being plateaued. There should be a reason, something beyond nutrition is my belief. So I think there is a huge other factors beyond nutrition also plays a part on growth. And physical activity is one of the other main factors which has a huge negative impact, where people do not balance these three in children. And children or human beings are meant to be physically active, which we are not being physically active. And then what they do is they sleep during daytime, they are up at night time using all the screen devices. And then what happens is, when the child is supposed to be active and driving, that activity force is the driving force to go and get hunger, develop hunger and eat, but that will be informed. So I think it's very important that we also looked, although nobody may see, because that's why I said nutrition is, the growth is not purely equal to nutrition. There are a lot of other factors, and especially the day movement or the 24-hour movement is very, very important. So growth monitoring is one of the most important things which we have to follow, and we have been using actually only the growth weight for height chart, which is not adequate in my opinion. I think weight for length chart is the most important chart which we should do periodically to find out whether the individual, because not only underweight, overweight, because in the weight for age chart, any downward deviation we take it as a negative, but we don't take that much of upward deviation as a positive or bad movement. So it's always better to put on the weight for length chart and see whether the individual is comparatively growing. So again, we looked at another small study which is on the timing of the pattern of growth faltering in children, and you could see that in this country, where at birth they are born with a fairly high SD score for length for age, the blue line, and the weight for age, red line, which drops around 3 to 4 months and then almost plateaus and takes off again after 1 year. So this is something which we have to address. And then you can see that by 4 months in the top line, about 50% show a weight faltering, downward trend of movement. So this is not a very good trend, and it has been maintained. And This is a small study which we have done in Colombo, but of course we have expanded this protocol, covering about 1,800 children all over the country in a, So I will stop there. So the main message is actually growth is a large component. Nutrition alone is not sufficient, and it has to be looked in a broader sense. Thank you.
Lucid explanation of really fundamental new concepts. I think he drew them into your mind very clearly. For example, when we were pediatricians, catch-up growth was what we taught for all low birth weights, that you have to catch up during. Now that is completely shown to be harmful. So I think that was one of the main take-home messages. I'm sorry that we are getting on time. Thank you very much, Pujita, for that lucid presentation. Now we get on to the next talk today, that is by Professor Aruna De Silva, who is a professor in pediatrics at the University of Vruna, and he's going to talk to us about trends and challenges in childhood obesity.
Good morning. Thank you very much, sir, for those kind words of introduction. I would like to thank the President, Dr. Dhammika Senanayaka, and the council members of the Nutritional Society of Sri Lanka for inviting me for the symposium lecture on trends and challenges in childhood obesity. This will be my outline. I'll be talking about the prevalence, diagnostic dilemmas and challenges, the etiology, complications, and the way forward during the next 20 minutes or so. Moving on to the prevalence of childhood obesity. According to the WHO, obesity has nearly tripled since 1975 worldwide. 340 million children and adolescents aged 5 to 19 were overweight or obese in 2016. 39 million children under the age of 5 were overweight or obese in 2020. Therefore, childhood obesity is one of the most serious public health challenges of the 21st century, with over 250 million children are predicted to be obese by 2030. This was once considered a problem of high-income countries. Overweight and obesity are now on the rise in low and middle-income countries, particularly in urban settings. In Africa, the number of overweight children under 5 years has increased by nearly 24% since 2000, and almost half of the children under 5 who are overweight or obese in 2019 lived in Asia. In keeping with the world trends, the prevalence of overweight and obesity has increased over the years both in urban and semi-urban areas in Sri Lanka. When we first started our study in 2014, prevalence of overweight and obesity among school children was 9.7% and 5% in Galle municipality area, amounting to a total of 14.7%. In 2018, in Batikolo, the total obesity and overweight percentage was 14.19, with a prevalence of obesity of 5.5% and overweight of 9.4%. In 2019, in Colombo, the prevalence of obesity was 10.3% and overweight was 11.3%, with a total of 21.6%. Compared to the Caucasians of the same BMI, Asians have 3 to 5% higher total body fat. South Asians in particular have especially high levels of body fat and are more prone to developing abdominal obesity, which may account to their high risk of type 2 diabetes and cardiovascular disease. Moving on to the diagnostic dilemmas. Before going on to the diagnosis, there are lots of definitions, different definitions of obesity. According to the WHO, obesity is defined as abnormal or excessive fat accumulation that may impair a person's health. According to the definition, the gold standard of measurement of body fat is DEXA. But as you can see, it requires bone densitometry scanner, trained personnel, and usually DEXA is not freely available. Another option is bioelectrical impedance analysis. It is a bit less complicated but has a few limitations. The commonest method that we use is the BMI-based diagnosis, as they are easier to measure, less time consuming and inexpensive. However, you have to keep in mind that they do not distinguish between the body fat and the lean body mass. For the BMI-based diagnosis, there are several recommendations such as the Center for Disease Control, CDC, International Obesity Task Force cutoffs, World Health Organization or the WHO cutoffs, and the Indian classification system. We conducted a study recently to compare the nutritional status among school children according to the different classification systems. A cross-sectional descriptive study among 833, which includes 48.37% boys, school children under the age of 5, at the age of 5 to 15 years in the Galle municipality area. Based on the results shown in this table, the prevalence of underweight, normal weight, overweight, and obesity were significantly different as determined by different international classification systems. The prevalence of obesity as determined by the other classification systems was significantly different compared to the currently practiced WHO classification system in our country. Hence, therefore, it emphasizes the urgent requirement of developing a country-specific classification system to accurately identify the nutritional status among Sri Lankan children. Moving on to the etiology. The etiology of childhood obesity is complex and multifactorial. There is evidence to suggest that the development of obesity and its comorbidities may be influenced by not only the genetic, metabolic, nutritional, socioeconomic, and physiological factors, but also intrauterine factors. Along with our cultural background, we all know that all three main meals consist a large portion of carbohydrates. As you can see, we eat a couple of portions of milk rice in the morning and a large portion of rice for lunch, and things like kottu and other lots of carb feed during our three main meals. And all these types of buns and other short eats are freely available in our doorstep every morning and evening. Of course, most kids have a very sedentary lifestyle due to busy schedules of their parents, urbanization causing lack of space for their children to play, and increased studying hours due to the competitive exams starting from year 5. But we studied about the pre- and perinatal predictors of childhood obesity. The effects, we took 834 newborns were recruited within a period of 1 month to determine the effects of maternal lipid levels during late pregnancy on the birth of large for gestational age newborns in a tertiary care setting in southern Sri Lanka. Out of the 834 newborns, birth weight of 12.5% newborns exceeded the 90th centile, and 4.86% newborns exceeded the 97th percentile. According to this table, there was a significant higher levels of serum triglyceride and significantly lower levels of serum HDL in mothers who delivered large for gestational age babies compared to the mothers who delivered appropriate for gestational age babies. Hence, maternal serum triglyceride levels and HDL cholesterol levels in the third trimester are significant predictors of the fetal size. Our results emphasize that the maternal TG levels are independently and positively correlated, while the HDL levels were negatively correlated with the birth weight of the newborn. We conducted another study to determine the cord leptin, C-peptide, and insulin levels in the large for gestational age newborns in Sri Lanka. Leptin, as you all know, is known as an adipocytokine, was identified as a product of the obese gene, which is member of the adipocytokine family. It is detectable in cord blood from early second trimester, and its level is in the cord blood increases in the parallel with the development of the fetal adipose tissue. According to the results of this study, significantly higher leptin and insulin and C-peptide concentrations were observed in infants born too large for gestational age compared to infants born appropriate for gestational age. Finding this relationship as early as neonatal period will be useful in prediction of risk factors and identification of infants who will be at risk of developing obesity-related complications during their childhood and adulthood. Moving on to the complications of childhood obesity, according to the Directorate of Non-Communicable Diseases, the total cost of the implementation of multi-sectoral action plan for the prevention of and control of non-communicable diseases over the period of 5 years from 2016 to 2020 was rupees 9.3 billion. The complications of childhood obesity significantly impacts on the individual's family and also as a country as a whole. Therefore, identification of childhood obesity and its complications at an early stage is very important to reduce the burden. So, I will be discussing about non-alcoholic steatohepatitis, obstructive sleep apnea and hyperventilation, dyslipidemia and glycemic control. We conducted a descriptive cross-sectional study on 97 children aged 5 to 15 years who had a BMI of above or equal to 85th percentile based on the CDC guidelines in southern province of Sri Lanka. Lipid profiles, ALT, GGT, blood glucose concentrations were estimated and HOMA-IR was calculated. Abdominal ultrasonography was performed in the diagnosis of NFLD in each study participant. Non-alcoholic fatty liver disease. Compared to the Caucasians, South Asians have a more adverse body fat distribution and are at a much higher risk of developing dyslipidemia and NFLD. Childhood obesity appears with an array of cardiovascular risk factors including combined dyslipidemias, insulin resistance and hypertension, and non-alcoholic fatty liver disease or the NFLD is the most prevalent form of chronic liver disease affecting 10 to 20% of general pediatric population. Within the next 10 years, it is expected to be the leading cause of liver pathology, liver failure, and indication for the liver transplantation in childhood and adolescence in the Western world. Non-alcoholic fatty liver disease is an emerging public health concern in both developed and developing countries. The prevalence in South Asians was about 16 to 30%, and out of that, 10 to 20% were children. In a small study done by Rajendrajit et al. In 2017, the prevalence of NFLD among adolescents living in an urban Sri Lankan community was 8.4%. Based on our study, 38.13% presented with NFLD according to the ultrasonography. Out of that, 32.98% had grade 1 fatty liver and 5.15% had grade 2 fatty liver. Altogether, 22.68 children had elevated alanine aminotransferase levels, and out of those children, a higher percentage was diagnosed as having NFLD. 9.27% children had elevated GGT levels, and out of them, majority was also diagnosed with NFLD. So accurate regular monitoring by performing lipid profiles, liver function tests, and ultrasonography is mandatory in obese children to minimize the long-term complications of NFLD and future pathogenesis of cardiovascular disease. Moving on to the dyslipidemias, 38.14% children had serum cholesterol above the normal limits, while 28.86% children had serum triglyceride concentrations above the normal levels. 17.5% children had serum LDL cholesterol levels above the normal levels, while 13.4% had HDL cholesterol levels below the normal levels. Moving on to the glycemic control, 97 children again were recruited for this study with a BMI of more than or equal to 85 percentile. Insulin resistance was calculated according to the fasting blood sugar and the HOMA-IR, where above the normal in both males and females, indicating a higher prevalence in insulin resistance in our cohort. We also conducted a study to screen obese children for obstructive sleep apnea in southern Sri Lanka. One of the main risk factors for obstructive sleep apnea is childhood obesity, which accounts for about 60% incidence in obese children. Although polysomnography is the gold standard, it is costly and difficult to be used in children. The objective of this study was to use the prediction tool called Modified Stop Bank tool in assessment of obstructive sleep apnea in overweight obese children in southern Sri Lanka. The same group of 97 obese children between 5 to 15 years were recruited, and the parameters which are included in the Modified Stop Bank questionnaire were used to diagnose obstructive sleep apnea in children. According to the results, 27.8% of the obese children had a higher risk of obstructive sleep apnea, and 49.5% of obese children had an intermediate risk of obstructive sleep apnea and hyperventilation. So, the way forward, in conclusion and recommendations, based on the data I proposed, the following recommendations are needed to break the vicious cycle of childhood obesity. Since childhood obesity has become a serious public health issue in Sri Lanka, we recommend to carry out multi-centered island-wide programs to identify the prevalence of obesity and its complications among children and adolescents, to identify the current status of the island. Community-allied health support on periodic monitoring, dietary, lifestyle modifications and psychological support is mandatory. Making social and physical environment where children live, learn and play more supportive for physical activity and healthy eating is also mandatory. Although accurate diagnosis of childhood obesity and its complications is essential, current diagnostic tools employed in Sri Lanka are not appropriate. Hence, therefore, childhood obesity must be considered a collective priority, and it is the responsibility of the stakeholders such as the Family Health Bureau, Sri Lanka College of Pediatricians and the Ministry of Health to facilitate and develop a well-accepted and a validated country-specific cutoff values for the diagnosis of childhood obesity and its complications. Screening for childhood obesity must be implemented at an early stage in life and refer children at risk to medical teams aiming at non-pharmacological management of complications. Public health awareness programs must be implemented with the mediation of the stakeholders. Finally, practical, feasible and acceptable policies developed and implemented in collaboration with all stakeholders will be beneficial to break the vicious cycle of obesity. I would like to acknowledge my heartfelt gratitude to all the children and their parents who participated voluntarily in our studies. And I would like to acknowledge the members of the research team who are there for their contributions. Thank you.
Thank you, Aruna, for that very clear and concise presentation. Again, with that fundamental message of having a country-specific tool for diagnosis of obesity. Now go on to the final presentation. It's by Dr. Navodata Battu, who is the first and the only consultant pediatric endocrinologist at the Lady Ridgeway Hospital. She's going to talk about the endocrine aspects of obesity.
Thank you, Professor, and also thank you very much for inviting me to talk to you on endocrinology and obesity among children. So I would like to do a little bit of an introduction and also to talk to you on endocrine causes and effects of endocrine system due to obesity and the environmental exposures and how it affects the endocrine system. So it is a chronic positive energy balance, as you already know, and this excess energy is stored as fat in adipocytes, which grow and increase in number, which is a risk factor for cardiovascular and metabolic diseases as well as cancer. And obesity during childhood affects growth. Not only undernutrition, even the obesity affects growth. And the studies have shown this advanced linear growth is related to negative cardiovascular health outcomes during the early childhood. And also it is associated with significant disturbances in endocrine function. Sometimes it's not sure whether it is endocrine dysfunction which has led to obesity or whether obesity has led to endocrine dysfunctions. Let me take you through this story. So what are the endocrine causes of obesity? Generally, Cushing's syndrome, hypothyroidism, growth hormone deficiency, and this syndrome called Roux-Hadnot syndrome are associated with obesity. But the clear picture in these patients is delayed bone age and poor linear growth. All these patients will have poor linear growth as opposed to weight gain. So they have high BMI, delayed bone age, and lower growth velocity. So this is one of my patients. She came at 11 years and 3 months with a bone age of 8 years. She is relatively short compared to her mother, and she came with a total cholesterol of 345 and a LDL of 230 milligrams per deciliter. And the TSH level was more than 100. If you can appreciate there, the weight is on the 50th centile and the height is just on the 3rd centile in this child. Cushing syndrome, these are twins of the same family. The person who is on your right side was given steroids. The commonest cause of childhood Cushing is exogenous steroids, exogenous Cushing. So this baby was given the mother has taken over-the-counter steroids for nasal obstruction and resulting in short stature and obesity compared to the sibling. They are from same economic background, same environment, same nutrition, but the growth is impaired because of the exogenous exposure to steroids. This is a girl with Roux-Hadnot, rapid onset obesity, hypoventilation, and neuroendocrine tumors. The remarkable feature here is after 2 to 3 years of age, there is a rapid weight gain without any underlying reason. And as opposed to that, height has maintained as it is, but the weight has increased rapidly over a year. So when you see such a patient, you have to think of some pathology rather than nutrition. Here we have to exclude Roux-Hadnot syndrome. This child had a mediastinal tumor. So we go all out to look for tumors in such a patient. In such a patient, when they come to you with rapid weight gain without any reason. There are some obesity syndromes. It's a monogenic obesity associated with genetic conditions. These are rare, but it is important to know. What happens is these patients will have severe obesity presenting during infancy. In addition to obesity, they can have associated hypothyroidism, growth hormone insufficiency, ACTH insufficiency, and some of them may have red hair. So these are all genetic or monogenic forms of obesity, very severe, and these patients do not respond to our dietary management. If it is a leptin deficiency, leptin is the treatment. We have to confirm the leptin deficiency by doing the genetic studies, and the treatment for those patients is leptin, nothing else. So there are patients with syndromes who are coming to you with obesity. A common syndrome is Prader-Willi syndrome, where the ghrelin level is high. I will explain what the importance of this. Bardet-Biedl syndrome, Alström syndrome, and Albright's hereditary osteodystrophy. So 3 of these conditions can be diagnosed by examining the hand. Patient with Prader-Willi will come to you with small hands and feet, almond-shaped eyes. Bardet-Biedl patients will have polydactyly. And Albright's hereditary dystrophy patients will have short 4th metacarpal. So when a patient comes to you with morbid obesity, examine the patient thoroughly, and even by looking at the hand, you can find out what the underlying diagnosis is. So what happened to our endocrine system? So all these organs, endocrine organs, get affected with obesity. Pancreas associated hyperinsulinemia. Adipose tissue became an endocrine organ after identifying leptin. So adipose tissue causes hyperleptinemia, pituitary gland, gonads, adrenal glands, gastrointestinal hormones, and even thyroid hormones get affected with obesity. So what happened to pancreas? It increased the insulin 3 to 4-fold in obese patients and resulting in insulin resistance. And we have seen insulin resistance more when the patients have central fat distribution as opposed to subcutaneous fat distribution. And there is increased secretion of non-esterified fatty acids that again modulate insulin sensitivity. And in these patients, beta cell functions decrease, and the chronically elevated non-esterified fatty acids are harmful to beta cells. All these can result in subsequent diabetes, insulin resistance, beta cell dysfunction, and the glucose toxicity, and which is called glucolipotoxicity, result in beta cell dysfunction, leading to diabetes at a later stage. So people think they grow, with obesity they tend to grow tall, yes. Unfortunately, the final adult height is not getting affected with obesity. So what happens is growth hormone secretion is decreased in obesity due to leptin, and studies have shown up to 6% per each unit increase in BMI, the growth hormone levels can go down. But low growth hormone level continue to maintain obesity. But this reduction in growth hormone secretion is reversible with weight loss. And the studies have shown there is this growth hormone independent growth in patients with obesity, where the insulin and leptin goes and acts on the growth plates. Because of that, even though the growth hormone secretion is low, they tend to grow tall. However, so why growth hormone secretion is low is the result is hyperinsulinemia, high leptin level, low ghrelin level, and low adiponectin level reduces the growth hormone secretion. But at the end, they come to the normal population height. Why? What happens is, children with obesity, they are taller at 6 years in boys and 8 years in girls compared to normal population due to high insulin and leptin, which goes and acts on the growth plates. But girls go through early puberty and boys go through late puberty due to high insulin levels, which downregulates sex hormone governing globulin, and it results in high bioavailable estrogen. This high bioavailable estrogen advances the bone age. And also the studies have shown there is this sex-specific leptin and gonadotrophin interaction. And these overweight and obese children tend to grow less during puberty. Usually the puberty growth spurt is around 10 to 15 centimeters, but they have a lower growth phase with obesity. And ultimately, by 12 years in boys and 9 years in girls, the height standard deviation curves converge, and there is no significant difference in the final height. Even though you think the overnutrition will increase the height, but that does not happen. Initially they will have accelerated growth rate, which is a negative marker for the cardiovascular risk in the future, but at the end, their height will be similar to the population, or their predicted adult height predicted by the genetics and the birth length. The final adult height is can be predictable by looking at the genetic potential of the parent's height as well as the birth length. Both of these things determine the final adult height, not the nutrition. So the commonly done endocrine test in patients with obesity is thyroid hormone TSH. Most of my patients who are referred to me will come with a TSH of 4 to 5 milli-international units per liter and considered as high. Yes, it is high compared to slim patients. What happens is there is this neuroendocrine dysfunction which leads to abnormal TSH production in obesity. It is not the TSH which has resulted in obesity, it is the obesity which has increased the thyroid's TSH hormones. And this increased TSH suggests that there is some level of hormone resistance, and their free T3 level is also go up because of the changes in monodeiodination pathway. And this is the result of high TSH level you see in the patients with obesity. You don't have to treat them. With the weight reduction, the TSH level will come down, and this is an adaptation process. So what happened to the reproductive system? The girls and boys, females will have high testosterone levels, high dihydrotestosterone levels, reduced sex hormone bindings, and then they go through early menarche and develop features of polycystic ovary disease. In males, they have reduction in total testosterone, sex hormone binding globulins are low, LH pulses are low, they have high estrogen level because adipose tissue produce estrogen from the available testosterone, resulting in impaired fertility. So these are the things you may have to address when you speak to patients with obesity, because they have already heard about diabetes, hypertension, dyslipidemia, and heart attacks, but some of these patients may come and tell you, yes, my parents are also fat, they don't have any problem. But if you address these things, they will hear, because these are the new information that they can gather other than the cardiovascular risk. So with obesity, there are 3 types of adipose tissue: white, beige, and brown adipose tissue. The size and the deposition varies in small children. So visceral and subcutaneous areas are more of white adipose tissue, and interscapular area you will see brown adipose tissue. So with obesity, the adipose tissue distribution, white and brown, changes. This is how the changes happen. White adipose tissue mainly in the abdominal area, and brown adipose tissue cells go down. So why it is important? It is an important endocrine organ now. It reduces adiponectin and increased leptin. This increased leptin increase the food intake and reduce the energy expenditure, resulting in energy mismatch and obesity. And reduce adiponectin increase glycemia and cardiovascular disease, ultimately resulting in the metabolic syndrome. So this is the normal, in a normal person, ghrelin is, before eating, the ghrelin levels are high, leptin levels are low, but after they eat, ghrelin levels go up, go down, and leptin levels go up. This is how a normal mechanism is. But this leptin is a metabolic signal of energy sufficiency and proportionate to the adipose mass and the nutritional status. And it is secreted mainly from the subcutaneous adipose tissue as opposed to visceral. And the patients with obesity have a resistant or insensitivity to leptin, and they continue to have high food intake and body fat levels. Even though the leptin levels are high, they continue to eat. Their appetite is not suppressed because they have a leptin resistance due to prolonged exposure to high levels of leptin. And also, it is this leptin which stimulates the kisspeptin and the hypothalamo-pituitary gonadal axis, resulting in early puberty. In normal people, when the stomach is empty, ghrelin levels are high, that is to increase appetite. And when the stomach is full, ghrelin level goes down and appetite is reduced. This is the normal mechanism. This is what the bariatric surgery does. It reduces the stomach volume, and the ghrelin secreting cells are reduced due to bariatric surgery. In obese patients, the ghrelin levels are low. This insulin resistance resulting in low ghrelin level, and the postprandial ghrelin suppression is also low, resulting in they feel hungrier at a lower level of ghrelin, and they are more sensitive to ghrelin, and they have prolonged intake of high calorie diet because they are generally having low ghrelin level, and also they have a resistance to ghrelin. That is why they continue to eat even though their ghrelin levels are high. This is an opposite of Prader-Willi syndrome, where their ghrelin levels are high. This is the other hormone which is important as a therapeutic measure also. It is an incretin hormone produced in the small intestine, stimulating glucose-dependent insulin release. It inhibits glucagon release after food, slows the gastric emptying, and reduces the food intake. This is a medicine now approved for children with obesity after 10 years of age. FDA approval is there, but it is only recommended for children who are unable to be managed with diet and exercise. If you cannot manage, if the BMI is more than 35, there are secondary problems, you can consider GLP-1, but it has to be given daily or weekly, and it is a continuous treatment. The moment you stop it, they will regain weight. So why do patients with obesity become hypertensive? They have high angiotensinogen expression in visceral adipose tissue. Angiotensin 2 is increased in subcutaneous tissue. Aldosterone levels are also high, resulting in hypertension, and this is reversible with weight reduction. So all renin-angiotensin system is affected with obesity, and weight reduction will reverse this. So this is, I think I would like to talk about endocrine disruptors a little bit more, because these are the chemicals that we get exposed to, and the endocrine, when we get exposed to these endocrine, these chemicals, the hormone action on the receptors change. That is why these are called endocrine disruptors. Even a small amount can significantly affect the biological system, and it can go across the generation. Even the person who is not exposed to that endocrine disruptor can acquire it from the parents. That is the danger of these endocrine disruptors. Some are obesogens, some are diabetogens. Where do you find these endocrine disruptors? Those are in plastics, fragrances, industrial waste, and pesticides. So this is a reason, very common reason, where we see obesity and other endocrine disorders commonly in our country, probably related to these endocrine disruptors. Even though our genetics, our mutations have not changed, our receptors are acting differently because of these endocrine disruptors. Gut microbiome, so there is evidence linking between obesity and change in gut microbiota. So the diversity and the richness of gut microbiota is also deranged in obese patients. This gut microbiota promote the absorption of energy and result in excessive accumulation of energy and weight gain. So what does gut microbiota do? It ferments hard to digest carbohydrate into short chain fatty acids. It is beneficial in energy metabolism. It can reduce systemic lipolysis and pro-inflammatory cytokines, and increase energy consumption and lipid oxidation. So healthy gut microbiota is important to prevent diabetes and obesity. So our gut microbiota has changed. We are getting exposed to endocrine disruptors, resulting in obesity, and it's going from generation to generation. And where we should break the cycle, we should break the cycle from the infancy, from early childhood, to prevent them getting exposed to endocrine disruptors, as well as to promote them having healthy gut microbiota. As Professor Pujitha said, indigenous food, natural food exposure will result in healthy gut microbiota, giving favorable future. I think my time is up. So food is obesity genes, intrauterine environment and epigenetics, decrease physical activity, uterine environment, infections, microbiome, all these things can result in obesity, and all these things can be overcome by healthy lifestyle, healthy living, and this has to be started from early infancy, even before the child is born, as Professor Pujitha mentioned in his lecture. Thank you very much for your patience.
Thank you. Now for trying to clarify the really complex interaction between endocrinology and obesity in a very short time. I think you did a fairly good job. Thank you. I think we have just about time for 3 questions. We started 35 minutes later. Maybe 3 questions from the audience would be welcome. Professor Chandrasekhara, go ahead.
Thank you very much for very informative presentation. All three presentations were really impressive. And most importantly that I want to ask from Professor Pujitha is because it's a part of actually my interest also in my PhD studies also. I did some animal model on this especially postnatal growth acceleration with that, and basically you mentioned very clearly that it's not just low birth weight, but postnatal growth acceleration is causing more trouble, more problems, and we experience in my animal model also that it's not only for the low birth weight offsprings, but for the it's passing through the next generation as well. So my question to you is, how does this targeted nutritional interventions currently we have in Sri Lanka we are practicing to promote the catch-up growth in children with low birth weight affect to the risk of their metabolic syndrome? I am asking about the current practices.
Yeah, the current practice actually is that now, I mean, the ideal would be to look for the body composition, but in a normal community screening, we can't go for that. So the best next is actually to have the proportionate growth where you match with the weight with the length and try to have a weight for length matching chart and go on that rather than just only following them with weight. Now, as I said earlier, we said that the weight should come into the designated normal level, basically -2 to +2 range if it is much below than that. But when that happens, parallel to that, there is a certain degree of length increment also. But beyond a certain point, then only the fat-free component, the fat component keep on rising. Because especially in diets like ours and beyond that also there are potential. So what we have to match is, from an anthropometric point of view, is whether the height or whether the weight is matching the length of the offspring, and take it on that based on the charts. So rather than just trying to catch and try to progress the weight, because length will go and stop at a point, but the weight should not keep on going. So that has to be also then stopped and maintained along that trajectory rather than independently going. So that's why I said, when even for other children also today, in today's context, looking at not only the weight for age chart, but actually the weight for length or the weight for height chart is much more important aspect in the monitoring and getting the proportionate, because that is the best we can get. If we can get body composition assessment, that would be the best, but we can't go that. So in public health settings, of course, the best is to wait for length or wait for height.
Okay, thank you. And one additional question I just want to ask. Don't you think that our existing Symposia program need to be revisited, reassessed?
Well, Symposia, of course, is a supplementary food item which has to be looked in a much more broader sense. And, starting from a targeted distribution, because everybody is getting that, the needy and the unneedy, especially the pregnant mothers, which we tried to stop through the circular, but it failed again. And I think it has to look in what is the objective of Symposia, on what aspect are we giving, because it has to be geared actually totally as a supplementary program, and it should be used judiciously, I think, rather than just as a doling out food item.
I think there is a very rich program awaiting us in the future also, so probably we should stop our symposium at this point now. Thank you very much. Unless there is a really pressing question from any other member of the audience. Any really pressing question that you want to clarify from any of the three speakers? I think all of them gave very clear messages, and explained very clearly the rationale behind them, and I hope you will go and reflect on those later and maybe clarify them during tea or lunch if you want to. Thank you very much for all three speakers. Can we show our appreciation in the usual manner? And now I hand over for the next symposium. Okay, I think we can quickly get through this thing about giving the tokens. Or can we do it later?
The end of Symposium 1. Now I would like to invite the Symposium Chair, Professor Narada Varnasurya, to give away the tokens of appreciation to the speakers. Professor Pujita Wickramasinghe. Professor Aruna de Silva. Dr. Navodata Pattu. I kindly request Professor Narada Varnasurya to remain on stage and would like to invite Dr. Dhammika Senanayake, the President of Nutrition Society of Sri Lanka, to give away the token of appreciation to Professor Narada Varnasurya, the Chair of Symposium 1.
Coming up is the second symposium of the scientific session titled Role of Nutritional Supplements in Human Well-Being. Let me invite Professor Ananda Chandrasekhara, Professor in Applied Nutrition, Wayamba University of Sri Lanka, to chair the symposium too. Over to you, sir.
Thank you very much. To start with the symposium, our plenary speaker, Professor Renuka Silva, he is going to speak to us about food first, or not always food only. Are dietary supplements safe and effective? To introduce Professor Renuka Silva, my colleague, is currently Chair Professor of the Department of Applied Nutrition at the Wayamba University of Sri Lanka. Professor Silva obtained his PhD from University of Reading, UK, and he has been serving in as an academic field for nutrition for more than 25 years. In addition to his role as in teaching and research at the university, he serves as a member of several scientific and technical committees on nutrition and health, and a consultant of UN organization. He is a former president of Nutrition Society of Sri Lanka. He is the recipient of several awards, research, and several international research grants. Currently, he is involved in research improving the consumption of fruits and vegetables, biodiversity and nutrition, household food security, nutritional status of athletes, and food literacy of school children. Over to you, Professor Renuka Silva.
Thank you very much for your the kind introduction, and I'm happy to deliver this the presentation at the Nutrition Society Annual Sessions 2024, which reminds me about more than 20 years ago. I brought some of my students those days from Wyoming University to the Nutrition Society. And the sessions were held at a low scale, but now we are in a different situation, and majority of the audience are some of the products that we produce from Wyoming University. So I'm very proud to be here among the former students, the postgraduate students, and many other undergraduate students, and also with the professionals in this nutrition discipline. Nutrition Society invited me to talk about the supplements, and then I thought of talking about the food and also the supplements. Some people think that the food must come first, and some others said always it must be food. So let's try to look at whether the food first or not always food only. So what are the dietary supplements? Are they safe and effective? Giving a broader definition of dietary supplements, it's a product other than tobacco which provides supporting thing to the diet, and that contains one or more dietary ingredients, including vitamins, minerals, and sometimes herbs, amino acids, and sometimes some other substances or their constituents, and they are taken in terms of capsules, tablets, liquids, right? And there are various kinds of the groups of supplements, multivitamins, multiminerals, vitamin mineral supplements, glucosamines, probiotics, prebiotics, and enzyme containing products, fish oil. So various things are used for various purposes, not only for the undernutrition but also for certain diseases. And also the supplements are widely used in Western countries, and especially in US. There are statistics available. More than 70% of the adults use supplements, and mainly the women, more than the men. More educated people and high socioeconomic groups consume supplements in Western populations. In addition to US, Denmark, South Korea, Australia, UK use a lot of the supplements. Many people use, but Sri Lanka, we don't know exactly what is the use of supplements. There are so many misconceptions about the dietary supplements. Some people say that natural is safer and better, therefore you can get these herbs which are popular in Sri Lankan culture, Asian culture. Some people say that more is better, so then more nutrients you get, you will get better health. Of course, as nutritionists, you know that that is wrong. It's been used for hundreds of years, so then there can't be any problems. So that's another popular idea. It can't hurt to take supplements along with my regular medicine, because I'm taking some medicine, so it doesn't matter. So I'm not going to give answers for all of these the questions, but let's see some of the answers based on the evidence. Interesting research. The survey was done by Sri Lankan scientists during the COVID period. So you can remember that 2 years ago, a lot of controversial discussions about the supplements for the curing COVID-19. And these researchers found that at least during this period, 25% of the survey population took supplements regularly, and another 30% took occasionally, and most of them took vitamin C. I am sure that you also tried the vitamin C and various other supplements during COVID period, thinking that they will cure or protect you. And high income category are more likely to take vitamin D and multivitamins, so those are findings. And the same group of researchers did some work on the weight loss supplements in Sri Lanka and found that there are more than 100 weight loss products. They categorize them as supplements. Among them, green tea, garcinia, and the caffeine and anhydrous, the products. And you know that there were controversial things in addition to the so-called pannier. There are some hospitals were connected, but later it was denied by the Ministry of Health and also those the hospitals. So there's no. So this is fake, and the French the news agencies also reported that the supplement falsely taught as a COVID-19 treatment in Sri Lanka. It's a scam. So now everyone knows that none of them worked during the COVID period. Right. I'm not going to talk about these things anymore, but I want to talk about the micronutrient deficiencies mainly, and how the supplements can support to overcome this the problem, specifically in Sri Lanka, based on the global evidence that we got. So all of you, we know that the micronutrient deficiencies have consequences throughout the life cycle, starting from infancy, childhood, adolescence, and the adulthood. Professor Pujita and others discuss mainly about the childhood obesity and the adiposity related things, and also the growth. But these micronutrient deficiencies are so important for the proper growth of the children, and not during the childhood, but that decides their future well-being, the cognition, intellectual development, etc. So specifically, iron, iodine, folate, vitamin A, and zinc are the deficiencies that have been found all over the world, as well as specifically the developing countries. So these slides give you a snapshot of the micronutrient deficiencies in Sri Lanka, the latest 2022 National Micronutrient Survey results, Part 1. You can see that anemia among different age groups, pregnant women 15%, and even the adolescents 18%. But iron deficiency is low. So it seems that the anemia, although we thought that it's because of the iron deficiency, but the latest results indicate that it's not because of the iron deficiency, but some other reasons. Because iron deficiency anemia is low, and vitamin D deficiency has been identified or maybe recognized as a problem which is becoming a public health problem. And you see that the different age groups have vitamin D deficiency, zinc deficiency, and some vitamin B12 deficiencies have been reported. In our dietary studies done by Wimber University, the large sample dietary studies, we found that some problem nutrients for women as well as children. Why do we call them as problem nutrients? Even if we predict that even if we improve the current dietary patterns, still it's very challenging, or it's nearly impossible to achieve these nutrients through our current dietary practices. So then we need to change the dietary pattern. So for women, the calcium is a problem, thiamine even, riboflavin, niacin, folate, and iron. For the children, niacin and vitamin A. Achieving those RDA values or RNI values would be a problem. And the studies found that the reason for this micronutrient deficiency is low consumption of nutrient-dense food. Especially you can see that the vegetables, green leafy vegetables, and the fruit consumption is so low. The recommendation is like 3 to 5 servings, but fruits and vegetable consumption is very low. But also you can see that the bottom line, the fish, meat, and eggs, pulses, the protein containing food consumption is also low. The recommendation hasn't been achieved. That's the situation in the country. Now let's look at what are the strategies and interventions specifically in children under 5 in the low middle income countries. So there are about, say, 5 strategies. Micronutrient supplementation. You can give single micronutrient like iodine, iron, folic acid, vitamin A, B12, vitamin D, zinc, or multiple micronutrients, combination of 3 or more. Lipid-based nutrient supplements. Large-scale fortification is a different strategy. That is adding micronutrients to commonly consumed food like maybe rice. Already we are using the rice fortification. Wheat flour, everyone knows that the salt is fortified, so that's a large-scale fortification. Or targeted fortification, that's adding micronutrients to the food given to specific groups like, say, school children. So iron fortified rice is given to the school meal programs in Sri Lanka. Whether you like it or not, whether you agree with that or not, it has been started. And also there's a point of use of fortification with micronutrient powders. When you are preparing the food, you add the sachet of the micronutrients to the pot, and that is the point of use fortification. And it has been well recognized and recognize that the supplementation is recommended when food-based approaches such as dietary modification, fortification, or food provisions are unable to achieve adequate intake. So food option is the number one, so food first. But if the food doesn't work due to many reasons. So for example, even the fortification may not be working because the children are eating very little quantities of food. So the fortified micronutrients, the intake might be low. In such a situation, the micronutrient supplementation has to be done. Right. So there's a recent review of the micronutrient supplementation and fortification interventions on health and development outcomes. So rest of the presentation is mainly based on this systematic review, whether iron, folate, and other supplementation for the under 5-year-old children are really effective. So let's look at the efficacy of vitamin A supplementation. Vitamin A, we give megadose of vitamin A in Sri Lanka, and compared to non-intervention or the placebo group, so these are based on the randomized controlled trials, vitamin A supplementation was found to reduce the risk of all-cause mortality by 10% of these children. So it reduces the all-cause mortality and increase the plasma retinol concentration. Right. So it's clearly vitamin A supplementation works. Zinc supplementation, they didn't find a significant effect on the risk of anemia, stunting, wasting, and all-cause mortality, but found that it reduces the risk of zinc deficiency and also incidence of diarrhea. So the zinc supplementation works well with this the under 5-year-old children. Iron supplementation, widely used in Sri Lanka for the pregnant mothers as well as for the children, school children. So this, the forest plot shows that the iron supplementation reduce the risk of anemia, but no significant effect on stunting and wasting, but you can reduce anemia, right? And it increases the hemoglobin concentration, and very importantly, iron supplementation improves the mental development and motor development, decrease the risk of iron deficiency. So iron supplementation, no question that it works with under 5-year-old children, according to the global statistics or the evidence. So how about the iron folic acid supplementation? Still, it works. You can see that the risk ratio is less than 1, and significantly reduce the risk of anemia and increase the hemoglobin concentration, and no difference, however, in incidence of diarrhea. So iron folic acid supplementation works. The efficacy of the mineral the supplements, again you see that here the multiple micronutrient supplementation reduce the risk of anemia significantly, increase the height and also the other growth parameters, increase ferritin, hemoglobin, retinol, zinc concentrations, and reduce iron deficiency. So multiple micronutrient supplementation works. And the micronutrient powders, yes, again it works. Reduce the risk of anemia. However, they didn't see any stunting, underweight, and wasting effects. Lipid-based nutrient supplementation, effective. Efficacy is high and reduce the risk of anemia once again. How about the fortification? Targeted fortification, adding nutrients to the food specifically consumed by the vulnerable groups. Again it works and reduce the risk of anemia and increase hemoglobin level, ferritin, retinol, reduce the iron deficiency, so on. So targeted fortification also works. And the large-scale food fortification with iron and multiple micronutrients, again it works. So you can see that not the single supplement of supplementation of iron, folate, but even the fortification works at the large scale and also the targeted level. Right. So then, supplementation of the nutrients, zinc supplementation during pregnancy is associated with significant reduction in preterm birth. Right? And supplementation, very important thing, and this requires not just supplementation. With supplementation, proper nutrition education programs must be conducted if you want to gain the full range of benefits or to make it sustainable. It's not just giving the supplements, but the parallel the programs must be conducted, and there are a lot of evidence since the early the decade. Many articles showed, as I mentioned earlier, the vitamin A, iron with folate supplements work. Right, and another publication says in Sri Lanka, as according to this article, supplementation and fortification can lead to an excess of vitamin A in Sri Lanka. Authors predict that there can be some risk because of so many foods are fortified So then therefore there are certain concerns, and also they said that the doctors, medical practitioners, need to consider prescribing iron and vitamin A containing multivitamins only when deficiencies detected and suspected, not recommended over-the-counter purchase of these vitamin and minerals according to this paper. Right. So in summary, we talk about the micronutrient supplementation for the, especially targeting the children. And based on the evidence, global evidence, local evidence show that micronutrient supplementation and fortification strategies are advocated or recommended for improving health and development outcomes among children under 5. So in Sri Lanka in the recent decade, micronutrient deficiencies and also overall nutritional deficiencies have come down, and now we are in a kind of a stagnated situation. Although we are suffering from sort of economic crisis at the moment, still we are doing well, better than some other countries in the region. And this is thanks to our micronutrient supplementation program. But as the previous speakers mentioned, now we need to think about some other strategies to further reduce the micronutrient deficiencies in the country. It's a cost-effective, short-term solution. Right? Supplementation does not address the root cause of the deficiency. The root cause is we are not eating sufficient amount of micronutrients from the food. So that has to be addressed. So for that, agriculture sector need a revolutionary change, and also the consumers need to think differently, and there must be some behavioral changes. So also we need to understand that there are different physiological responses and absorption than the nutrients present in food. The folic acid, zinc and iron present in food absorb differently than the supplementation. And the choice of intervention should be based on the root cause, and also depending on the severity of the micronutrient deficiency and the location. So geographical location, and it must be country specific, right? So I think you are very clear about this, the specific micronutrient programs. But now the next part of my presentation is about supplements and non-communicable diseases. Controversial. Do supplements protect against non-communicable diseases? Right. This shows the effect of nutritional supplements on dietary interventions on all-cause mortality. And the finding is important. None of the nutritional supplements or dietary interventions had no association with risk for this outcome. All-cause mortality cannot be reduced by taking supplements. If you think that taking supplements you can live longer, it doesn't work. Don't waste your money based on this evidence, right? And so this the review published in Annals of Internal Medicine is quite cited, well cited one. There are certain issues there. Let's look at specifically the cardiovascular disease. Any supplements work for cardiovascular disease? Sure, some of you might be taking fish oil supplements or vitamin supplements, antioxidants, thinking that the cardiovascular disease risk can be modified or reduced. Okay, what are the evidence? Lack of benefits of supplements on cardiovascular events, mostly among patients with risk factors. Lack of benefits, unfortunately. Randomized trials of folic acid alone or combination of vitamin B12, B6 found significant reductions in plasma homocysteine, and the total cardiovascular events were not reduced. It reduced the homocysteine, but the total cardiovascular events were not reduced. A reduced risk of stroke is associated with supplementation of homocysteine, lowering B vitamins. Right. So some benefits. And no consistent evidence to support the use of antioxidant supplements to reduce the cardiovascular risk. So the best thing is have your fruits and vegetables rather than going for antioxidant supplements if you want to reduce your cardiovascular risk. Because fruits and vegetable consumption clearly showed that 5 portions reduce the risk of many non-communicable diseases, but not antioxidant supplements. Women's Health Initiative, a calcium and vitamin D supplementation study, and also vitamin D omega-3 trial vital. No effect of vitamin D supplementation on cardiovascular disease. Omega-3 fatty acid 1 gram per day is not sufficient to reduce the cardiovascular disease risk. Some studies showed that if you take 4 grams of EPA, eicosapentaenoic acid, you may get some benefits. But 1 gram, so you need to check the dose. 4 gram is not in a usual capsule. It's 1 gram, which is not effective generally. And here again, this says effect of nutrition supplements and dietary interventions on cardiovascular mortality. None of the nutritional supplements or dietary interventions assessed had any association with risk of cardiovascular disease. No association. It does not work. And this gives a summary, right? So to help you to understand this crowded chart, let me tell you that the first column shows the interventions, various kind of the dietary supplements. And the black dot means evidence is very low. The certainty of evidence is very low. The green one, evidence is high. And now look at these the 4 arrows that I have highlighted there. You can see that the folic acid has beneficial effects on stroke. Okay, but evidence is low, but still there are benefits of reducing the stroke. The next one is the calcium and vitamin D supplementation has harmful effects on stroke. So it will increase the risk of stroke if you take calcium and vitamin D. You decide whether you are going to have bone injuries and get some problems or get heart attack. If you want to prevent probably the bone injuries or the fractures, you may take vitamin D and calcium. And omega-3 fatty acids is a big, the noise in the supplementation market shows that myocardial infarction, there are beneficial effects, however no strong evidence to say that. And the omega-3 long-chain polyunsaturated fatty acids, coronary heart disease risk beneficial effects but no strong evidence. So none of these supplements showed very strong evidence of reducing the cardiovascular disease. Cancer is same. Current evidence does not support a role of vitamin and mineral supplementation in reducing cancer risk, with some evidence suggesting potential harm. For example, folic acid exposure, high folic acid exposure, especially in the countries where the mandatory fortification of folic acid may promote cancer progression. And the beta-carotene supplementation increase the risk of lung cancer. So, all supplements do not give the benefits that we expect from the food which contain beta-carotene, which contain vitamin E. Look at vitamin E. Vitamin E supplementation was associated with 17% increase of prostate cancer risk among men. Right? So, Cancer, you can't get any benefits by taking supplements. And even fish oil supplementation does not reduce cancer risk. Type 2 diabetes, no more many studies. Current evidence does not support the use of supplements with vitamin C, E, beta carotene, fish oil to reduce the risk of type 2 diabetes. Osteoporosis, again, I am not going into details because the red light has been given for me the time. So, last part, I want to mention few things about recommendations of using dietary supplements in sports, taking a couple of minutes. Can we tell the athletes not to take dietary supplements and just go for food? Food first and always food only for athletes. It doesn't work for them, at least. Where practically possible, nutrients can be provided from foods and drink, but athletes cannot get the full range of benefits only from the food. Right. And the dietary supplements are commonly consumed by many athletes in Sri Lanka. Right. So let me give few examples why the athletes cannot 100% rely on food. They need high carbohydrates. Right? Very high carbohydrate diets on specific times, especially after the exercise period or the recovery period. They can't get that much of dietary carbohydrates. So they can get this carbohydrate high doses through gels, drinks, and powders. Right? Nitrates, the latest finding is that the nitrate reduce the oxygen cost of exercise by widening the diameter of the arteries. So, to get this nitrate, somebody has to consume beetroot juice or some other vegetable juice, but athletes can't eat large amount of leafy vegetables, so then they cannot get that benefit. So nitrite supplements. Gelatin is also the same. If they want, it has been shown that the gelatin, say 20 grams of gelatin prior to exercise increase the circulating collagen. To get this amount, they have to eat about 1 kilogram of chicken thigh. Impossible. So then supplements are required, and also the creatine supplements are required. They can't get this the amount of creatine on the correct time using food. So the athletes, there can be many examples, even the protein. So the protein, this is the last example that I want to mention. You know that the casein protein gives a slow supply of amino acids to the athletes during overnight period and improve their muscle protein synthesis. To give that protein from food during night is impossible. Impossible. Right? So then they have to drink 1 liter of milk, low-fat milk, or they have to eat 1 liter of low-fat yogurt to get that casein from food, which is impossible. So then they have to take the supplements. Right? Caffeine is also same. Right. So key messages to finish this the presentation. Use of supplements reduce the prevalence of nutritional deficiencies when people are not eating sufficient amount of food. When you are unable to get sufficient amount of nutrients from food, then supplements are okay. But not if you are generally eating well, you don't need supplements and it does not give any beneficial effects. So randomized trials evidence does not support use of vitamin, mineral and fish oil supplements to reduce the risk of non-communicable diseases. Globally, there has been substantial gains made to improve the nutritional status. However, there are still tremendous work has to be done to overcome this risk of micronutrient deficiencies. So probably now we need to deviate a little bit from this the supplementation and go for food options. Finally, further research to assess the long-term effects of supplements on the health of the general population and in individuals with specific nutritional needs are warranted. So thank you very much.
Thank you, Professor Renuka, for a very comprehensive presentation on supplementations. We'll move to the next presenter. I don't think that next presenter needs much more lengthy introduction because he's like a superstar in health and medical industry. Dr. Ananda Vijay Vikrama, Senior Consultant Physician at the IDH Hospital and Chairman of the National Medicines Regulatory Authority currently in Sri Lanka, and he is the current President of the Sri Lanka Medical Association. Over to you, Dr. Vijay Vikrama.
Good afternoon. Thank you very much, Professor Chandrasekhara, for that kind introduction. And I would like to first thank the organizers for giving me this opportunity to talk on this important subject. And of course, the previous speaker laid the foundation for my talk by showing how important in regulating these nutritional supplements, because there's so much of availability and so much of beliefs regarding supplements, we need to regulate this well. I purposely decided to give a short talk on this because I thought of using this opportunity for me as a learning exercise for me, because as the chairman of the regulatory authority, I think it is important that I learn on this from you all rather than you are listening to me. So I believe there will be some opportunity after this for a discussion. The Medicines Regulatory Authority was established in 2015 with the Parliamentary Act, and the functions started from 1st of July on 2015. As you can see, one of the important aspects were the regulation and control of registration, licensing, manufacture, importation, and all other aspects pertaining to medicines, medical devices, and borderline products. This is the main introduction to the Act. And the medicines in this Act means any substance or a mixture of substances manufactured, sold, offered for sale, or represented for use in diagnosis, treatment, mitigation, or prevention of disease, abnormal physical status, etc., or restoring and correcting modified functions of organs in man or animal, or medicine or a combination of medicine ready for use and placed on the market under special name and characteristic form. And then when we come to borderline products, the other category, there are three main categories for regulation: the medicines, devices, medical devices, and borderline products. We'll stick to the medicines and borderline products for the time being. When we talk on borderline products, it is defined in that as the products having combined characteristic medicines and foods, medicines and medical devices, or medicines and cosmetics. And in deciding whether a product is a borderline product, the following shall be taken into consideration: the intended use of the product, or its primary function and its mode of function, the therapeutic claim that the manufacturer makes about a product, the pharmacologically active substance, the concentration of the active substance, the level of efficacy of the active substance of the product, and the ingredients used and the concentration at which they are used. Now, we can start wondering, when we talk about supplements, to which category it belongs, to medicines, borderline products, or either. Now, this is one of the questions we had from the beginning, and I must say before that when we started the functions of the authority, our main focus was regarding medicines, for many reasons, and I believe many justifiable reasons. So the focus on borderline products was not that much. Of course, the authority at the beginning, we had a very limited staff, and even now we are having a limited staff. And due to various other issues, the main focus was put on the medicines, and then once the things improved on that to address the other issues, that was the plan at the beginning. However, things took more time. Cosmetics and nutraceuticals are two other areas which we deal with. Cosmetics means any substance or mixture. This is the definition in the Act. Manufactures of salt to use for cleaning, improving, or altering the complexion, skin, hair, teeth, and includes deodorants, perfumes, and cosmeceuticals. Nutraceutical means a product isolated or purified from food, which is generally sold in medicinal form, not usually associated with food, and provide physiological benefit. So using these, the supplements are mostly included in the borderline products, but you will understand the issues and problems we have. So we have a borderline products evaluation committee, and in the Act this is recognized as a separate area. Borderline products evaluation committee functions as the technical evaluation of products submitted for registration and so on. And these are the products which we evaluate at present. Oral or topical preparations such as multivitamins, multiminerals, amino acids, prebiotics and probiotics, glucosamine containing products, choline products, collagen containing products, toothpaste containing desensitizing agents, fish oil, antioxidants, methyl salicylate containing local applications, medicated plasters, etc. So you can see many of the things which was spoken during the previous presentation are included in this, but then still there are issues, as you understand or you will see. So if you talk about the process of registering, we have three main steps in registration of these products. First, we classify the product. When an application is made, we classify the product, that is, we decided whether it belongs to the medicines, borderline, or cosmetics, or whether it doesn't fall in this purview. And then if it is classified as a borderline product, a sample license process for imported products will be issued based on the classification. For local manufacturers, what is done is to get the formulation approval. And then the registration process starts. For the classification, we need many documents. After going through all these documents, the product will be classified, as I said, to whether it belongs to the borderline, medicines, and so on. And this includes many details, as you can see, including patient information leaflets, promotional materials, specimen, etc., in addition to the analysis of the finished product. And all applicants have to submit these to the borderline products, the committee, and it has to be mentioned in a specific format according to the guideline. For example, the minerals in elemental level, vitamins and in units, and then once the classification is done, a preliminary evaluation report will be issued, which will be valid for 1 year, and during that period they can apply for or sample license. And this classification, in addition to classifying it whether it belongs to medicines or borderline and so on, it will be classified according to schedules as well. So the schedules are the schedule 1, 2A and 2B, as you know. The schedule 1 is not necessary for retail sales license. Schedule 2A and 2B are sold only in pharmacies. And as you know, the 2B needs prescription because there can be risk associated with that. So after this classification process, the classification report will be issued. And then the registration process should start during this period. For this, first they have to apply for registration sample license and submit a sample with the application if it is an imported product. If it is a locally manufactured product, they have to give the formulation, and once that is approved, they have to give the application for registration. Now with this application, although I have put it in just in 3 lines, so many documents are needed according to the guideline. For example, for an imported product, 35 documents are needed, and for a locally manufactured product, 32 documents are needed. With the strengths of the various substance, etc. And then it is submitted to the, I'm sorry about the quality of this, is the picture is not very clear. Well, when the first, what is mentioned here is the first application is submitted, then it is classified, then it decided whether it qualifies as a borderline product or not. If it is classified, qualified as a borderline product, then if it is local manufacturer, they have to give the formulation approval, get the formulation approval, and then they submit the dossier for registration. If it is a foreign manufacturer, they have to give the obtain sample import license and produce the sample and the registration application, and which is evaluated by the borderline evaluation committee. Then there are other conditions. General sales borderline products and Schedule 2A borderline products are not permitted for ages below 2 years. And then therefore dose regimens for less than 2 years are not permitted on the label. A product containing a single active ingredient is considered as a drug, and you will wonder why this confusion is. For example, if it is only ferrous sulfate, that will be classified as a drug, whereas the combination of ferrous and folic acid will be classified as a borderline product. The glucosamine and glucosamine combinations are registered as borderline products, and all injections will be registered under pharmaceuticals. So these are the conditions which we use during the registration process. So as you have already realized, there are some or many overlapping and unclear areas. As I said in the example I quoted, the ferrous sulfate will be classified as a drug, whereas the ferrous sulfate and folic acid will be classified as a borderline product. So there are many gray areas. And then the food supplement, to make the situation worse, there had been a recent letter, not recent, issued several months ago, from the Ministry of Health to the Customs saying food supplements do not need registration. So that's why you see so many food supplements in the market without any evaluation and registration. They don't go through the Medicines Regulatory Authority, they don't go through Food Authority either. So that's an unfortunate situation which has been created several months before. Hopefully it will be corrected. And then in the list I showed you, you could have seen that the therapeutic formulas have not been included. So recently when we asked why it was not included, we understood that it was not included because we didn't have enough staff to go through evaluate these things. And obviously, it is something which has to be regulated because the need was highlighted in these. So the functions in the NMRA are still limited due to limited staff. And then some of these items come from the food authority, through the food authority. And unfortunately, there's very poor implementation of the laws regarding food and food supplements which do not come under the Medicines Regulatory Authority. So therefore, we see many supplements in the market which are unevaluated and unregistered. So it is, I think it is important that we all come together to decide on what needs to be regulated and how this should be regulated, whether as a food or whether as a borderline product or supplements, and then have proper regulatory methods to regulate these things, and also in addition to get the custom involved in that so that unregulated products will not come to the country, and also to have proper market surveillance system so that these unregulated ones which come to the market can be detected and necessary actions can be taken. Otherwise, as we all know, there's a huge promotion of these supplements through various means, and there's a huge market for these things. And some of these products we don't know whether they contain at least even the substance which they claim to have. So therefore, we are, when we talk about these food supplements and the other nutraceuticals, the situation in the country is very unsatisfactory. And as the regulator, I must accept that what we do is not enough. And the expertise we have for this is not enough. That is why we need your support. We have planned to improve the staff or correct the staff issue. So hopefully within a month or so we will have better status to address these issues. But of course we will need the support of the expert support from you all who know this subject. Thank you.
Thank you very much for very comprehensive presentation, and we'll move to the next presenter, Dr. Upeka Samaravikrama. Dr. Upeka is having MBBS degree and MSc in Human Nutrition and MD in Clinical Nutrition, and she is the consultant nutrition physician attached to District General Hospital of Gampaha. And her presentation is nutritional supplements for critical ill patients. Over to you, Dr. Upeka.
And thank you for the introduction. Thank you. My topic is nutrition supplements in critical ill patients. Next 20 to 25 minutes, we are going to discuss about nutrition supplements in critical ill patients. So, first of all, we'll see what is the definition of critical illness. Critical illness is a state of ill health with organ dysfunction, a high risk of imminent death if care is not provided. I'll repeat it. Critical illness is a state of ill health with vital organ dysfunction with a high risk of imminent death if care is not provided and the potential for reversibility. So the outline of my presentation is this. First, I'm going to discuss about why nutrition supplements are important in critical ill patients. Second one, when to start medical nutrition therapy. Third one, which route is better. Fourth one, what are the energy and protein goals. Next, when to achieve energy and protein goal, and nutrition supplements versus blend rice feeds, and which supplements to be given, in which conditions. So first we'll see why is nutrition support is important in critical ill patients. We all know that critical ill patients are in acute stress. There's hypermetabolic state and there's pre-existing malnutrition. 40% of our ICU patients, critical ill patients, are malnourished. Then there are metabolic pathways are altered. There's insulin resistant and hypercatabolism. Then 600 to 900 grams of lean body mass is lost per day during ICU stay. That's a huge amount, 600 to 900 of lean body mass, that is muscles. And if the more than 30% of the weight loss or the 50% of the lean body mass is lost, incompatible to life. There's 100% mortality if there are loss of 30% of the weight loss, or I'll repeat, 50% of the lean body mass. That's why nutrition support in critical ill patients are more important. Then we'll see when to start medical nutrition therapy. Medical nutrition therapy shall be considered for all patients staying in the ICU, mainly for more than 48 hours. So all the patients who are going to stay in the ICU for more than 48 hours, we have to start medical nutrition therapy. And begin with enteral nutrition feeding within 24 to 48 hours. We all know that enteral nutrition is like prior to parenteral nutrition. More advantages of enteral nutrition than parenteral nutrition. So we have to start enteral nutrition feeding within 24 to 48 hours in critical ill patient. If we discuss what are the metabolic pathways and what are the catabolism and all during ICU stay, there are two phases. First week, there's catabolic phase, and day 1 to day 2, there's early period, which is acute phase. Then the late phase is day 3 to day 7, no cutoff marks, roughly. Then after the 1 week, there's anabolism take place, which is the late phase or the rehabilitation. During first week, the metabolic instability and severe increase of catabolism take place. So endogenous energy production also there in the first week of ICU stay. So we should not overfeed the patient during the first week. Which route is better? As all the other patients, oral diet shall be preferred over the enteral nutrition or the parenteral nutrition in critical ill patients. If the patient can't get oral nutrition, that orally if the patient can't get the nutrient what he needs, so we have to go for early enteral nutrition. We should not delay, and we have to go for early enteral nutrition within 48 hours. There are patients with high risk of aspiration, so those patients we can consider post-pyloric, mainly jejunal feeds. But first thing we have to consider oral diet as normal, then enteral nutrition, then if there are high risk of aspiration, then post-pyloric or jejunal feeds. Then what is the energy and protein goal for an ICU patient? This is the indirect calorimetry, which we don't have. Indirect calorimetry is the gold standard for caloric assessment, and as we don't have indirect calorimetry here, we go for predictive equations, that is simple weight-based equations. So if we use simple weight-based equations such as 20 to 25 kilocal per kg per day, that is the first week we'll give only the 20 to 25 kilocal per kg per day, and protein 1.2 to 1.5 kg per day. Usually our normal requirement is 0.8, but in critical illness, protein requirement goes to 1.2 to 1.5. When to achieve energy and protein goal? Okay, hypocaloric nutrition, as I mentioned, like first week of ICU stay, we should not overfeed the patient. Only the 70% of the energy requirement should be administered in the early phase. That is the first week. To avoid overfeeding, early enteral nutrition or early full enteral or parenteral shall be prescribed within 3 to 7 days progressively. Progressively, like we are not overfeed in the first week, progressively we can achieve our target. That also only the 70% of the requirement, not the full requirement. Protein also same. During critical illness, 1.2 to 1.5 kilograms per kg per protein can be delivered progressively. If we achieve our energy and protein goal at the end of the first week, that will be adequate. The feeding should be advanced toward the goal during the first week. But if the patient requires severe hemodynamic support, that means if the patient's condition is unstable or the patient is on vasopressors and high doses of vasopressors and doses are increasing, we have to withhold the enteral nutrition or any nutrition. Enteral nutrition should be withheld and the patient is fully resuscitated. Then about the parenteral nutrition. When to use the parenteral nutrition? This side, if there are contraindication to oral or enteral nutrition, if the patient is not malnourished, we can wait. We can wait up to 1 week, not giving parenteral nutrition. We know that enteral nutrition is better than parenteral nutrition. There's high risk of infection with parenteral nutrition. So, if the patient is not malnourished, we can wait up to 1 week rather than starting parenteral nutrition. There's no hurry. If the patient is malnourished, this is different. If the patient is malnourished and enteral nutrition is not feasible, we have to start parenteral nutrition as soon as possible. It's two different conditions. If the patient is not malnourished, we can wait up to 1 week. If the patient is malnourished and there are contraindications to enteral, we have to start parenteral nutrition. Then the other one, which nutrition supplement versus blend rice feeds. Okay, this is a comparison of blended feeds and nutrition supplements or the formula. There's high risk of infection risk compared to formulas of blend rice feeds. And stability is poor with blended feeds, where the stability is good with formula feeds. Composition is inconsistent with blended feed, where the consistency is there are regular consistency in the formula feeds. Nutrient requirement difficult to reach with blended feed most of the times, easy to reach with formula feeds. Time for preparation is low with formulas compared to blended feeds, but a chance of tube clogging is high with blended feeds. But the cost is low with blended feeds compared to formula feeds. The customization can be done with the blended feeds. We can add whatever we want, and the formula feed we can't customization. But there are more favorable effect with the formula feed, but we don't usually use formula feeds in our ICU settings. 80 to 90% of the patient we use blended feed. Only on 10 to 20% of the patient, in case by case, we use formula feed because of the high cost. Most of the time, the 80 to 90% of the patients, we go for blended feeds. We prepare those feeds in the ICU setting. We have blenders and we prepare there. Then we go into categories of enteral formulae. Polymeric formulae. Polymerics are intact macronutrients, and maltodextrin as the carbohydrate source, and intact protein, and the lipid source is long-chain triglyceride. Then oligomeric formulas, those are pre-digested macronutrients, and the carbohydrate source is oligosaccharides, and peptide as the protein source, which is pre-digested, and medium-chain triglyceride as the fat source. And there are disease-specific formulas which can be given for diabetic patients, renal disease patients, and kidney failure, the renal failure patients. Then the modular formulas are there, which are available. All these formulas are available in Sri Lanka. A modular formulas concentrate protein or carbohydrate, where protein concentrate is an example for modular formula. Polymeric formulas contain micro and macronutrients based on dietary references. So we can cover the micro and macronutrient requirement with polymeric formulas. Majority are lactose free, and there are standard polymeric formula supply totally requirement of the micro and macronutrient. We don't need any other thing or the blend rice feed if we give total energy requirement through this polymeric formula. Then some definitions and some terms of formulas. What are the low energy formulas? The calorie densities, if the calorie density is less than 1 kilocal per ml, that is called low energy formula. If the calorie density is 1 to 1.2, we call it normal caloric formula. If the calorie density is more than 1.2 kilocal per ml, it is high energy. High protein formula means like it has more than 20% of the energy from proteins. High fat of more than 40% from energy from fat. MCH rich formula we give like where the absorption is poor conditions. Medium chain triglycerides are more. High MUFA. High MUFA formulas are monounsaturated fatty acid, more than 20% of the total energy from MUFA. In diabetic formulas, these are more than 20% of monounsaturated fatty acid are there. Then immune modulating formulas contain substrate to modulate the immunity, such as arginine, glutamine, omega-3, and nucleotides. Then, which supplements to be given in which conditions? Standard polymeric formulae, which when initiating enteral nutrition, we start with standard polymeric rather than other disease-specific or high energy formula. Disease-specific and severe fluid-restricted formula may be rarely used in small percentage, and where the standard polymeric formulas are not tolerating or in specific conditions, we give disease-specific formulas. Rarely. Standard polymeric formula contain 15 to 20% of energy. I have mentioned it before. 30% of energy from lipids, mainly long-chain triglyceride. 50 to 55% energy from carbohydrate, and energy density is 1 kilocal per ml, and it contains fiber. Then, if patient is not tolerating standard polymeric formulas, and in specific conditions, we go for oligomeric formulas, which are peptide based. There are the indications: when whole protein formula are not tolerated. Second one is when capacity for absorption is severely impaired, like short gut syndrome, short bowel syndrome. In the initial phase of after prolonged starvation, we give these peptide-based formulas because there is absorption is poor. Or the next one, when administration is through the jejunum. The previous slide I mentioned that we give sometimes jejunal feeds in severe acute pancreatitis or some conditions we give jejunal feeds. That case we give these partially digested formulas. Then in selected patients with short bowel syndrome and patients with intracutaneous fistula. So the absorption surface is low, like absorption surface is very short, so we give these pre-digested formulas to get the energy requirement. Then use of energy dense enteral formulas, where the fluid restricted energy dense nutrient formulation, which is concentrated 1.5 to 2 kilocal per ml, can be considered for patients with acute respiratory failure or patients with fluid restriction, renal or hepatic diseases. The immunomodulating formulas, the indications for immunomodulating formula, there are very few conditions we give. The grade 1 recommendation is the preoperatively, independent of nutrition status, where the major neck surgery for cancer, major upper and abdominal surgery, and after severe trauma, traumatic brain injury. Those are the grade A recommendations for immune modulating formulas. Grade B evidences are mild sepsis and ARDS, formula which contain omega-3 fatty acids. This is the summary. For the medical nutrition therapy for ICU patient, first we have to see whether the GI tract is intact. Whether the GI tract is intact, we can start the feeding with enteral formula within 24 to 48 hours. If GI tract is not intact, there's hemodynamic instability. So first we have to stabilize the patient, and IV fluid as needed we have to give. Then consider trophic feeds. Trophic feeds are the feeds we give to maintain the gut integrity. That is only we give the 10 ml per hour, like that, very small feeds to maintain only to the gut integrity, not to give the energy or protein. So most of the time, as I mentioned before, we give standard polymeric formulas. If the patient is not tolerating standard polymeric formulas, we can give partially digested. In few conditions like surgery, trauma, or burn, we give immunomodulating formulas or enteral formulas, but I have to repeat, this is very few condition and case by case basis. Most of the time, we manage the patients with blend rice food. So sepsis or septic shock or ARDS or anti-inflammatory enteral formula has a role. But we don't have those formulas in Sri Lanka. We have these standard enteral formulas and immunomodulating and fluid restricted formulas. This is the summary of my presentation. So I think I have covered all the objectives of my presentation. Thank you very much.
Thank you, Dr. Upeka, for very informative presentation. Now we have got very short, very small, questions. We have got time for 3 questions from all 3 presenters, Professor Renuka Silva, Dr. Ananda Wijekrama, and Dr. Upeka Samaravikrama. Audience can ask if you have any specific question relevant. A lot of questions are there, definitely. Okay, shall I start with the question? Because one of the concern about the regulation of supplement, my question goes to Dr. Vijay Vikrama, then maybe Professor Renuka also can add on that. Because the thing is, it's perceived as a counterproductive. Because of the current era, we are looking for nutraceuticals, nutrogenomics and all. So therefore, some of the rules may limit the access of potentially beneficial products and hinder the innovation and increase the cost of manufacturers. I mean, it's not my argument, it's there already. So what is your idea about that? I mean, how we are trying to balance while facilitating innovation for the future product development, not to. So how do you, what do you think about that? How we are going to address this issue?
At present, there is a fundamental difference between approval of medicines for registration and borderline products. The main difference is in medicines we consider the need. So we have a limited, for example, we have decided to limit the number of bands for a particular dosage form of a pharmaceutical. For example, for amoxicillin, we have decided it's only 15 bands we will register. But for nutraceuticals or supplements, there's no such restriction. And also certain new drugs, even though which have been proven to be efficacious, are not being approved because we think it is not cost effective for our country. That is for medicines. But for supplements, still we don't apply that sort of rule. So I don't think there is any problem in new ones coming to the market with innovations. There is no issues. What we would like to have is for the supplements which are to be properly regulated, so that we know those are produced with proper manufacturing conditions, under proper manufacturing conditions, and also contains what they say, what they claim that these products contain. Because unless these are regulated and unless the formulations are not looked into at least, we don't know what is coming to the market. So that is what we would like to know, at least for as the initial step. We might broaden the focus later, but at present that is what we want to do, so that I don't think there will be any restriction for new products or innovations coming to the market as long as they are manufactured properly. Thank you.
Adding to what Dr. Anand said, now the couple of things regarding the herbal products. The herbal products, of course, there can be some innovative products, and the new things are coming up which we don't have enough research to prove. But I think the regulatory bodies are considering the evidence. Without evidence, going for just for the claim is not accepted, because the regulatory authorities, as he mentioned, that their prime concern is the consumers. There can be a lot of unwanted products or the toxic products in these herbal things like alkaloids and some toxin products, which are not similar. For example, I know that Professor Anand is working on Garcinia and other products. It's very important to do research, but at the same time registering a product and telling that this is suitable for people, not undermining any nutraceutical or those are the so-called natural products, but the product itself may contain unwanted or undesirable concentration of certain substances. So that's the concern regarding the safety. The same thing is applicable to the sports, the supplements used by the athletes. The drugs or the medicines are going through a very strict scrutinized procedure in the manufacturing. However, these supplements, their quality, the assurance of the quality is questionable. So now, for example, in sports nutrition, these, although I mentioned that certain supplements may be beneficial, the problem is contamination. So it's against the anti-doping the thing. So then finally the athletes may get banned. So there are certain safety concerns which I did not mention in my relatively short presentation. But these are the things I think as a scientist we need to discuss, continue the dialogue, and as far as I know that these herbal products are not only regulated by NMRA, but also the Department of Indigenous Medicine has a role to play. Am I correct? Because I was also a member of the evaluation.
Actually, the herbal products are not regulated by the NMRA. Those are by the Ayurvedic. Yes.
Any other questions, please? Only one question, if you have. Okay.
Feeding critically ill patients, I would like to know that when you are feeding the ICU patients, you said that most of the time you try to go for the blended rice feeds compared to the formula feeds. Can you tell us if you go for the blended rice feeds, you 100% go for the blended rice feed dose, or you combine both formula feeds and blended rice feeds together to achieve the nutritional goals? How do you do that? Can you explain it a bit?
Thank you for your question. First, as I explained, like we first try with the blend rice feed because of the high cost, like no other reason, so they are so costly. So we try to achieve our energy and protein goal within blend rice feeds. Within 6 to 7 feeds, we can cover the energy and protein goal. If we can't cover with 6 to 7 feeds, we add another feed, sometimes 8 feeds. Still, if we can't cover the energy and protein goal, we go for the commercial feeds. That's also mixed feeding. We top up with commercial feeds. When we can't give the requirement of protein, most of the time we add whey protein to that blend rice feed. Like that we top up. We don't solely go for like this formula feeds due to the cost mainly.
Thank you very much. Actually, we have a lot of more questions relevant to this presentation, but since we are actually running out of time, so I must thank all three presenters for their very valuable, very informative presentation, and thank you very much for the audience. Thank you.
We have reached the end of Symposium 2. Now I would like to invite the Symposium Chair, Professor Ananda Chandrasekhara, to give away the tokens of appreciation to the speakers. Professor Lenuka Silva. Dr. Ananda Vijay Vikrama. Dr. Upeka Samaravikrama. I would kindly request Professor Ananda Chandrasekhara to remain on stage. I request Dr. Dhammika Senanayaka, the President of Nutrition Society of Sri Lanka, to be on stage to give away the token of appreciation to Professor Ananda Chandrasekhara, the Chair of Symposium 2. Thank you. Now we will break the sessions for lunch. I wish to draw your attention that the posters are displayed at outside. So poster presenters are requested to be on location. Poster evaluations will be started at 1:30 p.m. and will be evaluated by Mr. Wilfred Narammala, former Deputy Director of Sri Lanka Planning Service, and Dr. Harshi Gunawardena, Senior Lecturer, Wamba University of Sri Lanka. Afternoon sessions will be started at 2 p.m. Have an enjoyable time.